First of all, we would like to thank the organizing committee for giving us the opportunity to present a few results and experiences of prototype project that we have developed where we want to train by using virtual reality technology, train clinicians in learning the art of electroconvulsive therapy. So my name is Eivind Aakhus. I'm working as a senior consultant in old age psychiatry in Innlandet Hospital Trust, and this is
Rune Vandli. I'm the product manager at Vixel.
So, welcome to Safe ECT. We want to just give you a brief introduction to what kind of clinical setting that ECT is used, and it is used for depression. And depression is one of the most prevalent disorders worldwide, and it is a leading cause of disability according to the World Health Organization. And it is characterized by, well, everybody knows about, have heard about depression, but depression is also a mental health disorder which needs treatment. And it is characterized by a lowered mood, reduced interest, and reduced pleasure in things that usually give pleasure. And moderate and severe depression, they also affects the ability to work and to study and to live normal life with family and friends. It is also an important cause for suicidal thoughts or intentions and even actions. And most depressive episodes, they remit spontaneously, or they respond to psychotherapy or antidepressant medication. But however, a significant number of patients do not respond to standard treatment. And for those patients, ECT is an alternative, and even so, for some of these patients, ECT may be life-saving. So what is ECT, or electroconvulsive therapy? It is a treatment option for patients with moderate or severe depression. It is primarily for depressions that is not responsive to other standard treatment. And it is, to my knowledge, the most effective treatment modality known to psychiatry. And 60 to 70% of patients who receive ECT remits from their symptoms, that they leave the hospital symptom-free. And luckily, the more severe the depression is, the more effective is ECT. And it is especially well suited for elderly patients who suffer from depression, which is fortunate because elderly often don't tolerate antidepressant medication very well. So approximately 50% of patients in Scandinavia who receive ECT is 65 years or older. And ECT is the most common anesthesiological procedure performed in Norway, so it is quite usually used, offered to patients in mental health hospitals. And how do we apply the technique to patients? Well, on a sleeping patient, we applied a very small amount of current, electrical current, between two scalp electrodes. And the current induces an epileptic seizure that ceases spontaneously after 20 to 60 seconds. In our opinion, ECT is a matter of craftsmanship, and it requires an understanding of how the device, ECT device, is constructed and how it works. And it contains a number of buttons and wheels that the clinician has to know about. And we know from our experience when training ECT novices, clinical novices, that all those buttons and wheels may be some sort of distressing for them. And they are afraid to make errors. But they have to know about the device's facilities, and they have to know about the logical step-by-step procedure that is necessary to provide a safe and effective treatment. And they also have to know about how they can adjust the facilities on the device to improve clinical effect and reduce side effects by manipulating the current magnitude, the electrode placement, and the pulse width, and so on. So let's move to another subject, and that's about checklists in medicine, because checklists in medicine are very popular, but not so popular in psychiatry. It's most popular in the field of surgery and internal medicine, and has been used to a large degree, and it has been shown scientifically to increase patient safety and reduce adverse events and mortality in a lot of various surgical disciplines. Checklists are also used to a large degree in psychiatry, but have not been tested very much scientifically, and not at all in the field of ECT to our knowledge. So in our project group, we developed a checklist based on or inspired by the WHO surgery checklist. So we developed a checklist for ECT that guided the clinicians involved in the treatment through the session from the beginning to the end. And this includes both anesthesiologic and psychiatry-related items, and includes 3 steps. What should the clinician do prior to the treatment? And what should the clinician check immediately before treatment, or what we call the timeout session? And what should the clinicians do after the treatment when the patient is waking up? So we wanted to try this checklist in a virtual reality setting. And we couldn't develop a virtual reality program for the whole sequence, but we could develop for some of it, and we decided that we wanted to create the training program using virtual reality technology for the initial part of the training program, or the checklist, where we start by welcoming the patient and until the patient is ready to receive treatment. So we developed a step-by-step guidance which included 11 logical steps that the clinician should go through prior to administering the treatment. And I don't want to go into details with this, but this shows all the 11 steps. This starts with welcoming the patient and ensuring that the patient is not, has not eaten or having anything to drink before treatment. And it ends up by measuring the impedance and learning how to push the impedance test. And we're going to show you a movie which Rune is going to demonstrate, where he will tell a little about the technical issues and how Vixel solved the technical problems and solutions for the different problems. So, Rune, could you please?
Yeah. Yes. So the difficult problems about this is not to make the hospital room and practical demo, because you've probably seen a lot of demos like this. But in this project, the technical challenge was to connect a ECT operator and an anesthetic nurse. They can be anywhere in the world, and connect them into the same hospital room so they can collaborate together. So this was a collaboration challenge more than a technical VR challenge. So what you see there is that Eivind is performing the preparation for the ECT treatment, connecting the diodes onto the model or the patient. So you have more than one person inside that room, and you can see each other and talk to each other. So this is we made the system cloud-based, so that everything is synchronized across the internet. So you can be one person can be in Bergen and one can be in Hamar, and you can collaborate and work on the patient at the same time. We, Vixel, normally work on collaboration tools for construction. So we repurposed that system for this purpose. The technical challenge, or the user challenges in this, was to make it, to balance the user-friendliness with the realism. So if it was too realistic to press the buttons and to handle the tools, then the users wouldn't be able to do it. And if we made it too simple, then the realism would go away. So we tried a lot of different variations there. And also, as been mentioned earlier today, you have the challenges with the hardware as well. So we had to package the hardware so you could send a suitcase with the equipment to a hospital, and they will be able to use it directly without help. So the goal of this system is to be able to handle thousands of users in the pairs of 2 or 3 people at the same time in a hospital room and perform ECT training.
As you can see, the clinician who's training is guided by large virtual posters on the wall who tells him what to do. And he's also guided by these yellow arrows where he should put different things. And each correct action is rewarded with a green tick. And you are not able to move further to the next step until you receive this green reward. And you can see that he is actually shaking the bottle because he wants to get something out of it, because it's so realistic to stay in the virtual room.
And the guidance with the screens on the wall and the yellow arrows, that's the first time use help, which can be turned off when you want to have an exam to see if you actually remember the steps yourself.
And we have actually avoided a few hip fractures on people who are testing this program because they try to lean on the virtual bed that they believe is in the same room that they are. So luckily no one got hurt during the making of this film. Okay? No animals, no people. Okay, so the strengths of this project, in our opinion, is that Safe ECT allows clinicians to train endlessly in a virtual room before administering the treatment on real patients. And we think that this will increase the confidence of each clinician who is going to learn the art of ECT. And we think this online-based solution allows that the possibility that this allows expert and trainees to train together and communicate together regardless of where they are located geographically is a very good thing in this program. And of course there are some financial possibilities as well, because it's easy to translate this program and distribute it worldwide. Approximately half of the ECT world is using this model. So it's a large group who is interested in good quality training programs. So our further goals would be, first we try to share our experiences from developing this prototype in a scientific article that we submitted in a scientific journal recently, and hopefully it will be accepted very soon. And next week we will start training with clinicians who are going to learn the art of ECT. And then we have just started planning the phase 2 of this Safe ECT project. And in this phase 2, we will try to develop a complete training program from beginning to the start to the finishing the treatment, which will include all of the checklist. We will also include some sort of training where the clinician can train on assessing the quality measurements and interpreting the electroencephalogram or the EEG. And finally, in a planned phase 3, we will try to develop a program that simulates problems and challenges such as high impedance, which is sort of skin resistance between the two scalp electrodes, prolonged seizures, poor EEG quality, and anesthesiological complications, and so on. So we have a lot of plans and a lot to do for the next years, I think. So this is the project group that is including both people from Vixel and from Innlandet Hospital Trust. And we just want to thank you all for your attention.